In the interest of time, we will get rolling. I want to thank everyone today. I'm Terry Henner, University of Nevada, Reno School of Medicine, and I want to welcome you to today's webinar on open educational resources. My opening remarks will be brief, and then I'll turn this over to our two presenters. The first thing I want to mention is that this webinar will be recorded, and we'll be sending everyone a link to the archive presentation for later viewing. Next, I want to give special thanks to my behind-the-scenes collaborator, Karen Heskett from UC San Diego, for all her technical assistance. And finally, this presentation is sponsored by the Western Chapter of LiME, which is the Libraries and Medical Education Special Interest Group of the Group on Educational Affairs. So, by way of overview, wait, how did, sorry. Karen, these aren't scrolling.
Sylvia Kyle.
So what's the matter? Terry?
Wait, PowerPoint, because this not really
just double click on the next.
Okay, great. So by way of introduction, it's important to know that the defining characteristic of education OER is that it's licensed to allow for free use. That's really what it's all about, freely available, and in some cases they allow it to be freely modified, but there's a amount of variability in whether a resource can just simply be used or purpose for you.
Carrie Hargraves.
Hi, Carrie.
Yeah.
Hi. Thanks for getting me on.
Northern Virginia Community College.
Okay, so
as we like to be called.
Emily Brennan from MUSC.
Their phone. Somebody mute.
Karen, can you hear me?
I'm sorry, I guess a couple people are joining us a little bit afterwards. So the disadvantages of using free. So hopefully people can mute their own phones, because if I mute it in the system, I'm going to mute everyone except me, and you don't want to listen to just me. So we just need a little collaboration in keeping things quiet for this. And hopefully we've got everyone in on the phone system for now. So Terry, why don't you go ahead and go?
The concept of OERs really began around 2002, but they're really gaining traction. You can see a fairly radical move by this consortium of schools to abandon their textbooks and replace them with open access materials. In medical schools as well, they're examining how their institutions, faculty, and students might benefit from the adoption of OERs, open educational resources. And this is a white paper, an extensive white paper that's at university that may be of interest to people. Delves deeply into the topic to see what benefits would accrue, how they can encourage adoption, what obstacles. Okay, there are a number of kind of emerging online communities and organizations that are developing platforms, and they're designed for sharing materials and best practices in medical education. This is one called Open Pediatrics. And I'm just praying that my slides advance. There we go. Another group that is prominent and well established is called FOAM. It stands for Free Online Access to Meducation, and they are dedicated to creating, collating, and promoting access to health education resources. And their focus is primarily emergency medicine. And one of the laudable goals they hold is to make the world a better place. I apologize, these slides are not advancing smoothly. Okay, so where does that leave libraries in this arena? Well, there's tremendous opportunities in the open educational resource arena, and it builds conventional strengths of libraries in discovering, evaluating, curating resources. So here's an effort by a medical library to aggregate their locally developed OERs, for example. Another effort by a library is in creating a comprehensive gateway to e-textbooks and other resources. And then a natural extension of this is a recognition of a need for specialization within the library profession. And this is manifested by a very recent job posting advertising for an OER librarian who would lead the effort to develop and distribute and collate educational resources at their institution. So having said that, and thankfully I'm done with this introduction, I'm going to turn it over to our presenters who are truly some innovators in the field and making great advances in the realm of open education. And our first presenter is Dr. Rishi Desai, a pediatric infectious disease at Stanford, but with a public health background, who currently serves as the Chief Medical Officer at Osmosis and recently led the Khan Academy of Medicine. So Rishi, take it away.
Can you hear me now?
Yeah, I found you. Sorry.
Great. No problem. So in brief, I worked at Khan Academy and I work at Osmosis now, and this image is here to show us kind of what learning ought to look like, but in fact it looks a lot more like this most of the time in medical schools, a picture of frustration and isolation. A lot of students, as you know, ideally should be learning kind of in the orange bar things in class. They should be learning things in the blue bar for their USMLE and COMLEX exam, and ideally things in the green bar for their life. And these bars should kind of be completely overlapping, and if that was the case, that would be great. In fact, that's not always the case. I'm going to slide ahead. It's often more fragmented, and it looks a lot more like this, where there are some things taught in medical school that is not on the boards, and things that are taught, for life that is really not taught anywhere. And because some of these things are fragmented, students end up kind of looking for other resources to kind of fill in the gaps. And so classes start looking quite empty, right? So students end up opting out of even going to class because they think, well, what's the point? I need to go and prepare for my exams, or I need to go and study more efficiently. So things like high yield, and you hear all these buzzwords, and this empty classroom, lecture attendance nationally is 10 to 15%. This is a manifestation of this kind of choice that they end up having to make, as they're picking which things they want to study. So, of course, there's a market that's opened up, and students are paying gobs and gobs of money to go and get these resources. And, our idea was, fundamentally, if they're paying for these resources, why is it that they're even doing that? Why aren't they just learning in the classroom? When we know a lot of times class lectures are recorded, and here I have a slide back here that shows kind of the classic options in which classes are recorded. You have a blackboard, you have kind of a big talking head, you have a PowerPoint voiceover, or maybe some sort of work tutorial. These are usually the kinds of in-class resources they get. So why are they paying gobs of money for this stuff? And does that make any sense? And so our thought was, why don't we create free open access education or medicine in the same vein as what you just heard about, the foam movement, and why don't we create it, not just make it free, but really make it as good, if not better, than what's out there. And that's really the first point of kind of synthesis here is, what if we were to create something that's really quite excellent? And this is a question here that I'd pose to all 111 of you. Short, engaging medical videos that are freely available would be a good supplementary resource for your students and faculty. Do you agree slightly or strongly, or do you disagree slightly or strongly? And I'll just wait 10 seconds for you to respond to this. And it'd be nice to kind of see what folks are thinking. I'll just give 10 seconds for this now. And let's keep going then. So we did a little bit of research. We wanted to say, okay, we want to make things free, we get that, but what about quality and what about engagement? What's the data tell us? There's a citation here that's at the bottom. Guo did a fantastic paper on MOOCs, and particularly looking at edX videos and Khan Academy videos, and found that if you look at video lengths, you have 0 to 3 minutes, 3 to 6, 6 to 9, 9 to 12, and 12 and over, and engagement time, you see that engagement time really maxes out in that 6 to 9 minute range. And this is a median red bar with the 25 and 75% confidence intervals, or 25% and 75% intervals listed, not confidence intervals, as the blue bars. So you can see 6 to 9 seems like kind of an ideal range. After that, making a longer video actually decreases time engaged, which is actually quite interesting. So that's one data point we were just looking at. Another was looking at the actual style of video. So going back to those 4 styles I showed earlier, the idea that you have, a talking head. Let me just pull it up real fast. You have these 4 styles here. A talking head, a chalkboard style, a tutorial, or some sort of voiceover PowerPoint. Of these, is there any advantage to doing one versus another? And what we found was that actually, let me slide over. What we found is that actually using something that's a little bit more engaging increases engagement. So not surprising. So con-style videos do a little bit better than a voiceover PowerPoint or a tutorial that's done as a talking head. So that's the red line or orange line versus the green line. So at each length of video, the more engaging version of it did better. So that's actually kind of good to know. And then we also looked at the speaking rate. So how many words per minute does someone speak? And where do you see the peak engagement? You can see for any length of video, speaking faster essentially gets you a better retention or better engagement, audience retention. So, and this is true of if you've worked in medical schools, you know that most students will do what they call 2x, and if they could, they might even 3 or 4x any video, right? So they just listen to it on double speed. So it's a very common habit that people have, and this goes in line with what we're seeing. In fact, even the longest videos, 12 to 40-minute videos, even if they were faster, engagement would be higher. So it's very clear that speaking faster seems to engage people a little bit better. Now, keeping all these things in mind, we started making content. So I used to work at Khan Academy, and I've switched now to work at Osmosis. We started making, and I should point out, all this stuff is completely free of charge. There's no reason anyone on this call couldn't just jump in and start looking at it and using it. But all these videos we started making on topics like HIV and Crohn's disease and hypertension and autism, Wilson's disease, really trying to say what would really engage someone is something that is really to the point, highly visual, animated, really, really kind of interesting and funny if possible, and multimedia. So in the bottom right, I included a video that shows mitral valve regurg. We actually have a sound of that regurgitation murmur in the video. So you can actually watch the video, see that little hash mark between S1 and S2, and also listen to the murmur. So really making it as engaging as possible. So with that in mind, we actually also want to make it short, right? So this is our timestamp. In the bottom right, you can see I circled in blue, 5 minutes and 48 seconds on this video, which covers congenital heart defects. So really kind of learning from that data and saying, okay, let's really apply this in real life. Now, another common kind of error is around cognitive load. How much do you express to a learner and how quickly? On the left is what people typically do. They kind of quickly run into a wall and think that you're going to just learn everything right at once, whereas we found that having a more graded kind of response makes it much more engaging. So for example, our video on jaundice and tetralogy of Fallot and this upper one, I think it's on Alzheimer's, starts out really kind of simple, really engaging with a little animation here. You've got a hippopotamus going down a chain of microtubule. And by the end of it, but it's not to say that we're trying to make them simplistic. By the end, you can see they get quite complicated. So this is the same video, jaundice, tetralogy of Fallot, and Alzheimer's disease, but you can see it started really simple and kind of ramped up. And that's the idea. You don't want to slam people into information that just doesn't work. We also try to put some operant conditioning in there where we actually put little sounds and we put little funny stories to kind of give people almost a treat as they're going through the video so it doesn't feel boring. So there's a visual stimulus. It's actually quite interesting and funny as you're learning. We've actually been doing this with medical schools. So actually Rush University Rush Medical College recently been working with UC Berkeley, Kaiser Permanente, so hospital chains, have actually been partnering with us to create content. They said, look, we've got subject matter expertise. You guys obviously have a fantastic animation team. Work with us to make videos together. And this is something that I invite anyone on this call to kind of reach out to me about, because this is something we're definitely looking to do. We also have free and open access questions. So we have an entire question bank generated to target these topics. So you can learn about things like warfarin, and then you can go and answer questions about it. And this is an example of one of our questions. We've taken all this content, all these videos and questions, all of which are free. We got it paid for through Robert Wood Johnson Foundation grant. We also have a partnership with NBME around looking at how this stuff works in medical schools. And we're getting it all translated and putting it offline under a CC BY-SA license, and it's all on Wikipedia. And I'll show you a screenshot of that in a minute. But basically trying to get this content out in as many channels as possible, letting medical students know that this stuff exists. This is our Open Osmosis library. If you want to go check it out right now, if you have a browser, you're welcome to check it out. This is the website. But we have videos on all sorts of topics, as you can see, and the question banks that I just pointed out on a number of different topics. So you can literally kind of dive in and start looking and poking around if you'd like to. So, oh yeah, right. So a question Scott just asked a good question. It says, goes against the point that shouldn't spend gobs of money, blah, blah, blah. Great question. Open Osmosis is completely different than Osmosis, and that's why I'm directing people to the Open Osmosis site. In short, Osmosis basically gives completely free content that anyone can use for free. You don't have to pay a thing for it, not a dollar. And so, again, you just go to this website. You'll see what I mean. It links to YouTube where everything is completely open and free. You can check it out. Okay, so our videos, as I said, are under an open license. To kind of prove the point, we've started putting all our videos on Wikipedia. So if you go to Wikipedia, for example, under Zika virus, you can see in the bottom right there's a thumbnail. You can click on that, and you can see it's an Open Osmosis video. So all of our videos, pneumonia, HIV, tuberculosis, all of them are on Wikipedia pages for English, but also getting them translated into other languages. So all of our videos are being translated into these languages that are kind of bullet pointed, and you can see a screenshot of our Thai translation here for Zika virus, because Zika has been translated to many more languages. So the idea is, again, to make the videos, put them out in as many channels as possible, get them out on YouTube. And again, that link gets you to our YouTube site, as well as getting the questions out there as well. So this is our kind of average use per month, 500,000 views on the videos. And just today, being Wednesday, we have 15,000 views on our videos, 1 million problems completed, and again, just today, being Wednesday, 35,000 questions being completed. So again, this is all being done by students around the world, in different languages, and I should stress, completely free of charge. This is some of the faculty feedback. So this is feedback from one of our nursing faculty from College of St. Benedict, from Jody. You can read the line. And also Matthew Craybill from Ross, University School of Medicine. I just want to highlight the second part. I appreciate the fact that they use the most current diagnostic criteria, but also reference the older criteria to talk about what's changed and why. These videos are not meant to be a replacement for what you get in the classroom. It's meant to be supplementary, and we go through great lengths to identify updated information and try to present that as often as possible. So this is just some of the faculty feedback. This is some of the student feedback. You can see nursing students and medical students. At the moment, it's pretty evenly split in terms of our audience. We get a lot of nursing students watching these videos as well as medical students. And it says, Annalise says, can you talk a little bit more about problems completed? How does that tie into videos? Right now, at the end of videos, you can go to another video. What we're going to be doing in the next month is at the end of videos, you can click on do a quiz, and it'll give you a free quiz on that video that you just did. So it's, again, in line with kind of knowing that when you have questions tied to videos, engagement goes up, and we're going to have questions specifically tied to each video available for free. And we're trying to figure out how to get that to work through Wikipedia as well. Patient feedback, this is kind of one of the most interesting things. Again, patients aren't paying for this stuff. It's free. But they basically get access to all this stuff as well if they want it. And a lot of communities have popped up. This person looked at our video on autoimmune hepatitis to understand how that works. So this is a paper we wrote about open osmosis and the OER that we've created. We did this in conjunction with Robert Wood Johnson Foundation. They funded this project on the auspice or on the precondition that it would be completely free of charge. And here's a question. The main reason I believe students and faculty may not be using these OER resources is, and then you can check off the box, and I'll just wait 15 seconds. And if you have questions for me, please feel free to type them in the side. I'm doing my darndest to answer them as I go along. And you can see as you get the answers on the right-hand side, most people are not aware of them, but there's a lot of folks around faculty not trusting internet resources, which I think is really good to know. And then faculty think it's not effective. And that's where I'd be curious to kind of understand exactly why they think it's not effective, and maybe if there's an interesting dialogue that can come out of that, whether it's based on just kind of an assumption or whether they've seen it and they feel like, gosh, this isn't really quite the way I like to teach it, which is totally reasonable as well. But I see this group as being, hopefully for the 60 and 57 respondents that say they don't know how to, Michael says, don't know how to integrate with the curriculum. It's a great point, and actually I'm going to get into that right now in the last couple minutes that we have. So how do you actually use this stuff in a curriculum? And someone asked about how the videos and the questions tie in. There is technology out there, and someone alluded to osmosis and the cost of it. There is actually, even with the platform that is offered by Osmosis, there's a free piece of it. And all the stuff I'm talking about right now is completely free. So I want to stress that for the rest of this conversation. All the technology I'm pointing out is still free. And if you're curious about it some more, please ping me afterwards. Will it be sustainable after the grant funding runs out? It is actually. A lot of the funding now that we're getting is through schools that are partnering with us to make the content. So we have a pretty sustainable path there. And there is a paid part of the platform, which I've agreed not to talk about today, but that's where we're also planning on getting funding for the open education resources as well. Not to mention grants that we have already lined up. So the idea then is if you have a video-based resource, you can add a question to it. And this is what we're adding right now. The beautiful thing is that we don't just add questions as a one-time quiz. We find out if you got it right or wrong, and this idea of spaced repetition. So to explain spaced repetition, the idea is you get a question. Let's say you get it right today. This is April 13th. We'll ask you that same question 2 weeks, 3 weeks, and 4 weeks later. If you get it wrong today, we'll crunch down the time. We'll ask you more quickly that question again. If you get it wrong again, we'll crunch down the time again. So 5 days, 3 days, and then if you get it right, we'll space it out 2, 3, 4 weeks. So that's what spaced repetition means. And what we do is we say, okay, which questions did a student get right? Let's say they got these 3 questions, these facts right, fact 5, 9, and 18. Then and only then do they qualify for this clinical question. So we kind of scaffold up these kind of recall questions to more challenging questions. And then what we do is we ask students, before they answer, tell me your confidence level. Are you sure you got this right? Are you feeling lucky, or do you have no clue? And we published a paper about this. And so what we found is that men and women actually equally get things right, but men are more often going to say that they're sure, even when they're wrong. And women will often say that they're not sure, have no clue, even when they get it right. So this is a paper we published about kind of association between confidence and accuracy. But the idea is that we ask them to kind of rate their confidence, then we ask them to answer the question, and we get a learning fingerprint, right? So we know kind of, did they get it right, how quickly, and how confident. And over time, you can kind of measure their confidence on different questions and different concepts. And then we use that to recommend videos. This is the loop that then gets created. You have blended learning opportunities where videos pop up. Let's say today's video is on pneumonia. You answer a question, you get it right or wrong, you answer a tougher question. Then we say, hey, gosh, you have a gap here. You should go back and watch that pneumonia video. And this can keep going not just for a semester, but can go on for an entire year or 2 years. So again, instead of this binge and purge where students learn something, then they take a midterm or an exam, and then they forget it all the way until they take the boards, and then they forget it again, we're challenging them to constantly remember information. And the idea is that then you can also take school resources. So this is a school's PowerPoint, not something made by Osmosis. And instead of uploading to Canvas or Blackboard, we present questions alongside of that. So it's kind of natural language processing. We also present kind of real-life patient videos and other resources as well, and then allow students to actually generate questions themselves and crowdsource questions. So within a school, you can have Emory University or Florida State University can actually create its own questions for this PDF. And that's what you have on the right-hand side. So basically, student A can write a question, then student B can answer, and then student B can edit that question, up or down vote it, and then comment on that question as well. And that's probably the most common use of our platform that we're seeing. So ultimately what it gets to is this idea of self-study, so that you get all this data back on how students are doing on the questions and how confident they are. And then in the classroom then, you basically have opportunities of mentorship, kind of simulations, and doing all the human-type skills that we think are so important. So we've definitely published a few papers. I'm at the end of my time, and I'll end with this final question. And I know we don't have too much time right now, so I'm happy to pass it along to the next presenter, and maybe at the very end, if there are questions, I'd be happy to take them, or if there are any that want to get typed out right now, I can answer in the next maybe 1 minute. And I apologize in advance for the quickness of all this. As I've mentioned a few times, feel free to reach out to me or email me individually if you have any questions. This is my email address, and I'd be happy to chat with any of you. I realize that these webinars can be hard for individual conversations, but we do our best.
And now we're going to move on to our next presenter, who is Dr. Julie Chilton, a child psychiatrist and assistant clinical professor at the Yale Child Study Center. And most importantly, in this context, she is associate editor of the IACAPAP e-textbook of child and adolescent mental health. And just a quick reminder for everyone to keep your phones muted during the presentation. Okay, Julie.
All right, can everybody hear me?
I can hear you.
Okay.
Julie, go ahead.
All right, thank you so much. Thanks for having me today. And Rishi, that's such an amazing project. I'm so glad that I got to learn about it today as well. And I'm going to speak faster because I learned from you that that's going to hold your attention better. So thanks for that. So here I am today talking specifically about a project helping to address the shortage in child psychiatry. So a bit more specific than Rishi's talk, so I hope you'll humor me in terms of the specificity of my talk. And this organization that has put out this free online textbook is the International Association for Child and Adolescent Psychiatry and Allied Professions. This organization is a very much international organization that started in 1935 and really tries to promote education and caring for the world's children, especially in low and middle income countries. And it's not just for psychiatrists, but also for social workers and psychologists, all kinds of people who work in the mental health field. So my objective for today is to tell you a little bit about our free online textbook, how it was created, what made it possible, how it really came about, and really how it has changed since its inception, and what kind of impact it has made and hopefully will continue to make and evolve. So I wanted to say a little bit to give you a background about how I first got involved and how the creation of the virtual curriculum came about. So I'm a child psychiatrist, but a long time ago, before I went to medical school, I did a neonatology medical mission in Romania. And, this was in the early 2000s. Actually, this was in the late 1990s. And there were still not a lot of resources in Romania. And as I was shadowing this neonatology team, I was noticing that the doctors were explaining that there were boxes in the corner of ventilators and respirators to help these infants breathe, but they were just handbagging infants and at times having to choose between which infants to handbag because they didn't know how to operate the equipment that had been donated to them by the World Health Organization. So I really saw firsthand how people and children were suffering from a lack of information, not even resources, but just information. And when I left Romania, my thank you present to the resident who had taught me so much while I was there for the summer was a huge box of pediatric textbooks because she didn't really have a lot of textbooks. Then in 2010, once I became a psychiatrist, I was finishing up my residency at Penn, and they sent me to Botswana for a month to figure out if there might be a need to send residents to Botswana to teach and learn about mental health care in Botswana. And, you know, I knew at that point that I was going to be going into child psychiatry, so I was interested in spending some time with the pediatric clinicians. And the gentleman you'll see here on the left, Noah Nguni, was an ER physician who was in charge of the entire psychiatric clinic, though he had no formal psychiatric training, simply because he was the one guy in the ER that was pretty empathic to these people who were mentally ill that came in. And when I asked him about why there weren't psychiatrists working there, or even child psychiatrists, you know, he quickly explained that there was one child psychiatrist in the entire country, 6 adult psychiatrists total, and no psychiatric training program, and really it was quite stigmatized, and there was no way for even the medical students to get interested in psychiatry, as there was nobody to teach little tidbits about mental health care at the early stages of medical training, when you might actually stimulate people's interest to go into it. And the few who did go into psychiatry would have to leave Botswana and either go to South Africa or to the United Kingdom or to Australia for training, and often would not return as they found, you know, lucrative positions. And so Botswana continued to have this dearth of child psychiatric mental health providers. What was interesting is while I was there, they were building a beautiful medical school across the street from this psychiatric clinic that you see here. And they had nobody to teach a psychiatric curriculum, child psychiatric curriculum. And Dr. Nguni, of course, after I left, was grateful to have all of my textbooks because he did not have any psychiatric textbooks. So again, I saw this real problem in terms of education. And unfortunately, that's not unusual. I'm sure you've heard in the U.S. how there's a shortage of child psychiatrists. Well, here's the rate of psychiatrists per 100,000 population by WHO member states. And you'll see most of Africa is light blue. This very light blue just means there wasn't data available, but the gentler blue here shows less than 0.5 psychiatrists per 100,000 population. And when you look at the rest of the world, you know, here we are, the United States at 14 per 100,000 population. Switzerland is, you know, the wealthiest in terms of psychiatric resources at 40 per 100,000, but even the U.S., in terms of the more well-resourced countries, is not doing so hot. And when you look at the World Health Organization's Atlas study, specifically about child psychiatrists, not general psychiatrists, there are only 1 to 4 per million population in most of Africa, the Eastern Mediterranean, Southeast Asian, and Western Pacific countries. In Africa, there are roughly 10 child psychiatrists outside of South Africa versus Europe, where we'll see the numbers are much better. And unfortunately, as I mentioned, similar to Botswana, where there's no training program, half to two-thirds of the child mental health training needs are unmet worldwide, and this is a bigger problem in low and middle income countries. And only South Africa had a formal training program, as I said, in child psychiatry. And there are some changes. There's a new program in Nigeria, but there's still a huge shortage. So the people that end up providing the care are often pediatricians or adult psychiatrists, and unfortunately even pediatricians, most of them that do provide this care, are not trained in child and adolescent mental health. So there's even in places where there are people providing care, they don't have any training. Even in the United States, you see here, look at the middle of our country. This dark blue means only one child psychiatrist per county. The eastern seaboard, of course, and California look a lot better, but even in the United States, we have a huge shortage. And when you look at where the shortages are, you'll see that the only place where there isn't a shortage, I don't know if you can even see this, is actually D.C., where I practice. There are 64 child psychiatrists just in D.C., and that is the only part of the United States where there is not a shortage. So what do we do to combat this problem? And, I think this is a great quote from Ping. So knowledge is the enemy of disease. Applying what we know already will have a bigger impact on health and disease than any drug or technology likely to be introduced in the next decade. So how do we disseminate this knowledge? How do we train the people who are out there actually providing the care, though they haven't had full fellowships or even residencies, some of them? So there is a new massive open online course put out by IACAPAP that is based on the online free textbook. The World Health Organization is trying to train primary care physicians and GPs through their program. And we have started a volunteer teaching medical mission program through IACAPAP that is also based on the MHGAP from the World Health Organization and the online textbook. So let's go ahead and talk about this textbook that we keep mentioning. So I did my fellowship at Yale, and we were given on day one this big, wonderful Lewis's Child and Adolescent Psychiatry textbook that runs about $250 on Amazon. And this is a gift to us from the editors, Anders Martin and Fred Volkmar. And I frankly didn't have a lot of time to open it, as it is more of a research-oriented book and didn't necessarily have a lot of clinical friendly resources, and didn't get a ton of use for me during fellowship. And I actually decided to stay on and teach at the Yale Child Study Center once I finished, and I was in charge of teaching all of the first-year psychology, social work, and child psychiatry fellows, organizing their course. And we decided to not use this, typical standard textbook, but instead to switch to this online IACAPAP textbook, because we felt that it would give us a more broad understanding of global child psychiatry rather than the kind of typical Kool-Aid that every more regional area offers you, as Lewis's Child and Adolescent Psychiatry is full of a lot of expertise from the Yale community. So we felt that switching to this online textbook would give us the benefits of having more clinical resources at hand, which are incorporated into the book, and it's more international and can be updated. Oftentimes, by the time these typical textbooks are published, the information is out of date. And so, what is the story with this textbook? It was launched by Dr. Joseph Ray, a Spaniard who relocated to Australia, so a truly international guy, who from the beginning wanted it to be free and online, and he started it in 2010, recruiting international authors from a truly multicultural group of people, and everybody's work was voluntary. So far, there have been no grants. This is all volunteerism that was organized by Dr. Ray. And Dr. Ray is a child psychiatrist who specializes in adolescent depression and the use of ECT. And from its beginnings, with links to wonderful clinically useful scales, patient video clips, there's easy access to research articles that are seminal in the field for each diagnostic chapter. There are links to internet advocacy and support groups, and most interesting, I think, when you find an area you're interested in, there are often lectures you can click on and get another 30 minutes of additional learning on a topic of your interest. So the fact that it's a truly virtual internet, web-based living document gives you so many more resources than a paper textbook. Also, it's illustrated and wonderful photographs that you might not be able to afford in a typical paper textbook. And since its development, we have added things to truly make it a virtual curriculum. So each chapter, we are developing PowerPoints to go with each chapter so that a busy clinician who doesn't have time to create a real evidence-based lecture from scratch can take the chapter on, let's say, schizophrenia, download the PowerPoint, adapt it to their use, and use it without any charge. Additionally, if you're using that PowerPoint to teach a group of students, you can use the end of chapter questions and the clinical exercises associated with each chapter to teach that particular diagnosis. And since then, we've also added many more chapters. We're now up to 57 chapters, and it's been translated into many languages as well. And, these advantages have been mentioned before, but the traditional textbooks really are expensive, and you can't update them as easily, and they're really more reflective of their place of origin and their author's place of origin than a truly international realm. And what I think has really allowed for this textbook's success is the complete transition to ebook sales. Even in 2011, Amazon had more ebook sales than print sales, and now that the internet availability is much better in low and middle income countries as well, it makes these things possible. And my colleagues in Botswana and Romania at the time could not have afforded a $250 textbook that might be out of date in a few years anyway. There is also data that clinicians prefer to use internet searches and PubMed than opening a paper textbook anyway. And this has shown to be true in low and middle income countries as well. And though there are still places where internet coverage is spotty, for instance, we just had a pilot teaching mission in Addis Ababa, Ethiopia, where you had to download individual chapters and leave them on desktops for the students because the internet access was so spotty. That is getting better and better. So the access issue is similar to what Rishi said, the gold open access, the Creative Commons attribution non-commercial license, so you're allowed to use it, distribute it, reproduce it, just have to cite it, and you can't, use it for financial gain. Some technological issues, just so you understand the technology behind it, it is launched in a PDF format on the IACAPAP website, and each chapter is downloaded individually. And that way you can update chapters one by one without having to shut down the whole site. Unfortunately, because of that, there isn't a search facility, and there's only a generic find tool on the Acrobat reader. Outcome measures are not so easy. So we know that 180,000 plus page views have happened, but we don't know if those are the same people, different people, who's getting them. That we're not clear on. Unfortunately, we wanted to have a lot of reader interaction and created a Facebook page for questions and back and forth conversation, but that hasn't been that successful. So that would be an area that could certainly improve. And then it's also available on iTunes and Google Play now. So I'll just quickly take you through a chapter so you can see why I love it so much. Here is the IACAPAP website, and then down here you'll see the icon for the textbook. And I'll show you the Autism Spectrum Disorders website. You see there it's got a version translated in French, and it truly is a multicultural authorship. There's a Spanish, Nigerian, American, Mexican, Tunisian, and Turkish author. It really, given that it's not print, we can throw in all these colorful anecdotes, links to all the important papers where you just click. You don't have to go searching for things on PubMed. And then here are those wonderful lectures where if you want to know more about, Susan Sweeto and the DSM-5 changes, or Psychopharm from Dr. Martin, you can browse further. And then especially important, I think, is the patient video clips. So really, what are the red flags of autism? Let's see it firsthand, and you just click and learn. Certainly also, clinicians are using these chapters for the resources, not just to learn. And here you have the MCHAT and diagnostic instruments for ASD. And then beautiful artwork can be included. And our autism PowerPoint is under construction, but I'll show you here, in the depression chapter, you see there's a PowerPoint associated with it. Here's an example of the self-directed learning exercises and self-assessment that can be used by any teacher. And then the answers as well, and the PowerPoint slides. These are kind of what those look like. And we've gotten some fairly positive reviews. Also, the readership, here's the breakdown by country, which is also international, so that's great from our point of view, and all the different translations that are happening. And the textbook really is being used in a lot of places, from the Karolinska Institute in Sweden to South America to the United States at Yale and Maine Medical Center to Lithuania. A lot of people are using it. And it is now actually the backbone of this massive open online course that had 2,000 students involved in its pilot. The authors from that were from all over the world, and it was also on our website and based on the textbook. So really you can use the textbook for quite a few different things that can be built from it. And when you look at further projects in the MOOC, the Massive Open Online Course, we talk about the teaching project, where you can be a volunteer part of the medical mission using the textbook PowerPoints and go all over the world teaching child psychiatry. So with that, I think I'll end there, as I know we have some questions. Sorry to talk so fast, and thank you very much.
Great, Julie. This is Karen, and so we do have two questions for you. I'm going to sort of rephrase one from Robert. He asked about handling copyright terms for the various elements in your textbook, and how do you handle that? And I know you had the Creative Commons license there, so it sort of leaves the assumption that everything, every image, video, specialty thing like that is created by the authors and is not used or reused from other textbooks. Is that correct?
Well, anything that has been put in there has been put in there with permission under the Creative Commons license. So everything is fine for you to use and copy and disseminate from the textbook.
Great. And Robert also asked if the book integrates well with an EMR system.
That one is tough for me to answer. Could you explain a bit further?
Okay. Well, maybe Robert can explain a little bit. I don't know if we can, he can try unmuting his phone or just typing in some information, but we'll wait for some feedback from him. While he's doing that, there is one other question, so we'll sort of juggle this since our time is short. There was a question for Rishi, and that question was, Students may replace the in-house learning experiences, i.e. lectures, with outside resources, but there is limited interactive opportunities with such videos.
Yeah, thank you. Yeah, that's fantastic. In brief, these videos on average, we have to keep in mind, these are 6-minute videos, right? 6-7-minute videos. The idea is that you can have a student, and actually what we see is that in a lot of schools, they'll literally just say, look, we expect you to watch these videos outside. They're 6 minutes, 7 minutes. They're not lengthy. When you create a video, you can be very, very meticulous and cognizant of words, and we are very tight with our scripts. So sometimes students will watch a video once or sometimes twice or 3 times. So they'll watch these videos if they need to multiple times, and then they come in and they're ready to go. And that's kind of the idea. Now, there are many things that we have to do in terms of faculty development and actually training our faculty to not just be lecturers, but to really be coaches then. And there's a whole other talk I could do on how we do that. But then the idea is that in-house, they are actually having some sort of interactive experience rather than sitting in their classrooms and literally being lectured at for an hour, which is the most typical thing that I see.
All right, great. And so Robert did write back with some clarification.
Yes, and
go ahead.
You definitely, as long as you have internet access, you can pull up this book.
Can you do it from within the EMR? So we know that they could go to another screen, but is there any way that, like up to date, you can click on a button and go out to up to date? Is there any way that direct access is facilitated?
I suppose you could do a hyperlink into your EMR and click on the hyperlink, and it would open up the IACAPAP page. That's the only thing I could think of.
Okay, but you don't have anything already created for that?
No.
Okay.
But that's a great idea. I'll bring it back to the team.
Are there any other questions that people have?
Okay, this is Terry Henner again. Seeing no other questions, I would like to simply thank our 2 presenters for some outstanding presentations. Fascinating, and I'm sure you all agree. We're sending out email with a link to the archive and also a link to a survey, just a follow-up survey to the class, an evaluation of the presentation. And we'd appreciate your participation in that, full participation. So thank you very much, Rishi, Julie. Thank you to all our attendants. Last question for, or one last opportunity for questions, and I'm sure the presenters would be happy to take any follow-up questions via email that occur to you. Okay, so I will bid you all farewell then. Have a good day, everyone.